So good to see you streaming in from the waiting room. Good morning or good afternoon, I should say. Wonderful to see you all. Welcome, welcome. I'll cover some housekeeping items while everyone's getting connected to their audio and video. Let's see. So there are there's either closed captions, subtitles, or a transcript option that we have turned on. People tell us sometimes it's helpful to be able to see the words on the screen as well as listen, but you do have control of that. So to toggle that option on or off, the More button on the bottom of the menu, the three dot ellipsis, if you click that, you can choose subtitles or transcript, or I think maybe even you can see our captions in another language. I don't know. Let's see. Also, for the beginning portion of the program, we'll have everybody in mute, but the chat features your line of communication. So I invite everyone to give it a try and type in the chat where you're tuning in from. Where are you in the country or maybe the world? Every so often, sometimes I'm surprised by people in Australia tuning in at 4 a.m. or who knows where. So always good to see where people are. And if anyone has technical questions, my colleague Kelly, if you'll raise your hand, Kelly, put them in the chat and Kelly can help you troubleshoot. If you can't hear or see or have any questions at all, she is our Zoom pro. This program is also going to be recorded, so if the content seems, if the content's getting complex and you want to go back and watch it again, we're recording it. So you'll be able to do that, and you can access that from our website or our YouTube channel as well. Okay, well, I think that's all our housekeeping items. So I will, let's get started. Welcome, my name's Andrea Merriam. I'm with Parkinson and Movement Disorder Alliance, and we're so thrilled to be your host today for this online program. Today we were talking with Dr. Neal Hermanowicz, and before you all joined in the from the waiting room, we were talking about Dr. Hermanowicz and where he's from. So you can see where everyone's tuning in from in the chat, Dr. Hermanowicz, but tell us where you're from and where you're joining us from today.
Well, I'm joining you from Santa Fe, New Mexico, which is where I reside and work here at Christus St. Vincent Medical Center. Getting a little chilly here in Santa Fe. But Santa Fe is in so many respects a long way away from where I'm originally from. I grew up in central Illinois, mostly, and mostly in a town called Normal. So I grew up in Normal, Illinois. I lived on Normal Avenue in Normal, Illinois, through high school. And college, my parents were mostly still there. So that's my background. My wife likes to say now that I'm in Santa Fe, I'm far from normal. That's her joke.
That's a pretty good line.
Doesn't get tired of that one.
And so Dr. Hermanowicz is a movement disorder specialist, a board certified neurologist. He's had a very illustrious career, has practiced in Southern California at UC Irvine and is now in beautiful Santa Fe. Very jealous. That is such a cool city. And we asked him to talk to us today about Parkinson's disease psychosis. I believe many of you probably clicked on the link to register. It's Unpacking Parkinson's Disease Psychosis. It can be a complex group of symptoms, and Dr. Hermanowicz has actually throughout your career, right? You've participated in clinical trials, and it's been a passion of yours. So perfect guest to talk more about this. Before we dive in, I thought we'd start with we'll start by kind of giving an overview of Parkinson's disease psychosis. But before we dive into that, Did you want to add anything about, some of your research or, how through your career you've worked with Parkinson's disease psychosis?
Well, yes. So I did a fellowship at the University of Michigan many years ago. I finished my 2-year fellowship in 1991. And during the course of my fellowship, I did encounter it, people with psychosis. Just as an aside, I don't like the term psychosis. It's so off-putting. I remember I was in a meeting with some of my colleagues, and I said, I don't like that word psychosis. And somebody said, well, what should we call it? And I didn't have an alternative. I don't know what else to call it, but psychosis referring to hallucinations or delusional thoughts. So I guess that's such an unpleasant term, and it conveys other things that are not really relevant to Parkinson's disease. So when I was in my fellowship in Ann Arbor, I encountered it. Not too often, and I think not too often because I wasn't looking for it. I encountered it when it sort of poked me in the eye. I had no choice. And I remember one fellow in particular that one man, my patient, who I had placed on a medication called trihexyphenidyl, or Artane is the other name for it, which I don't use anymore. And soon thereafter, I got a message from him or his wife that he was having hallucinations. The hallucinations then, at least in my impression then, and I'm not saying the people who trained me taught me this necessarily, but I thought, oh, it's a medication side effect, but in fact, it's not. It's a part of Parkinson's disease, and it's not Parkinson's disease does so many things. There's so many things to talk about, but it is potentially a part of Parkinson's. Not everybody, but it does occur fairly often. And I started paying a lot more attention to it after I finished my fellowship and I was in my first job, which happened to be in Albuquerque a long time ago, 91 to 96. And I ran into it again. And some of the encounters with these symptoms were very unpleasant. Unpleasant for everybody, unpleasant for my patient, unpleasant for their spouse, unpleasant for me. All around, it was just unpleasant. And it led sometimes to people being removed from their home or having other serious consequences. And that impressed upon me then that I needed to pay more attention. And I learned that lesson more than once, that I needed to pay more attention. And that lesson has been ingrained in my work ever since, early in my career, that I've paid more attention to it. Not because everybody's going to have it, that's not the case, but because when it does occur, it can lead to something quite troubling. And if it's bad, it can get to the list of all the things that bother people with Parkinson's and their families and their care partners. It can get to the top of the list in a hurry. So that's why I've started paying more attention to it.
Well, we thank you for that attention throughout your career. I do think the little that I know, you have been, groundbreaking and really pushing the envelope to make sure that this is more of a focus in neurology. So let's get started with, I thought we'd go the good old who, what, where, when, why. And a good point that Parkinson's disease psychosis is kind of a loaded term. So maybe I'll try hallucinations and delusional thoughts. So let's start with the who, what, where, when, why, and who. Who does this?
Well, the person at risk for having these kinds of symptoms, hallucinations, which by the way, are more common than delusions. Hallucinations being a perception in some way that there's something there that is not in fact there. They're almost always visual, but I was talking to somebody earlier today, one of my patients, who was having auditory hallucinations. Those are less common, but they do sometimes occur. That same person was also having tactile hallucinations, feeling, oh, there are bugs crawling on me, get them off, which I've heard many times. It's not terribly common. Not everybody who has hallucinations has those, but I've heard it many times over the years. And delusions are ideas that are not really based in reality, that people get stuck on, and there's really no evidence to support them. The delusions are often, well, they're always unpleasant. The hallucinations sometimes are not unpleasant, but the delusions are always unpleasant, almost always. The delusions take the form commonly of paranoia. Somebody's out to get me. Somebody wants to break in to my house and steal my collection of seashells or whatever, or my spouse, my care partner, who's been so kind to me over the years. We've been married 50 years, for example, is now trying to harm me in some way. Or the medications that my care partner is giving me are poisonous and are intended to harm me. And sometimes those delusions take an even more uncommon form, meaning a delusion of misidentification. My spouse looks like my spouse, sounds like my spouse, smells like my spouse, but is not my spouse. That person is an imposter. It's got a name, it's called Capgras syndrome, named after a psychiatrist. I can't imagine anything more awful, tormenting than living in your home and thinking, I'm not safe in my own home, and that person that looks like my wife is not my wife. That's a stranger who may be up to nasty intent. And that has to be a very unpleasant situation for everybody, for the person, the patient with those experiences, and for the care partner, the spouse also. I can't think of what could be more unsettling. And that has on occasion led to difficulties, to the point that I've had patients who had to leave their home escorted by the police. And that's the kind of thing I don't want repeated with my patients, that something like that happens. So anybody with Parkinson's, I'm sorry, but anybody, the person who at risk is somebody with Parkinson's disease. And it's not a medication side effect necessarily. The medications may enable the emergence of these things or bring them out. But there have been reports, including from a good group in Barcelona a few years ago, that people early, untreated for Parkinson's disease, no medications for Parkinson's, had mild hallucinations, a sense of presence. So there's somebody over here, or somebody passed by, or there's somebody standing behind me, even without taking medication for Parkinson's disease. So that's the risk, is having that diagnosis.
And one follow-up who question, is it later on in the disease progression? Any data on when?
Yes, but don't be fooled by the data. That I'm alert to it now, as I was not early in my career. I'm alert to it now at the get-go. So if anybody's listening who's a patient of mine here or the past, you know that I ask people, those of you who know me know that I ask people oftentimes at the first visit, have these things occurred to you? And I typically ask them at subsequent visits, on every visit, because I want to know. And I want people to become accustomed to talking about it, being aware of it, even if it never happens. I need to know about that sort of thing, even if it's not something that warrants treatment at that time. Yeah, there have been a variety of risk factors that have been associated with people with Parkinson's who may develop psychosis, hallucinations later, cognitive impairment or dementia being one. But the NIH definition of Parkinson's psychosis, there's that unpleasant term again, does not require the presence of dementia or cognitive impairment, nor does it require the presence of medication treatment for Parkinson's disease. So I'm on my toes, I hope, for it, whether it's early in the game or some years down the line after living with Parkinson's disease.
And to normalize it, oh, I didn't even mean to make a normal joke, but to normalize it, what are those questions that you ask your patients early on?
I ask them very directly, have you had any hallucinations? For example, have you seen people in your home that other people don't notice? Have you seen animals or people passing in the periphery of your vision? Animals often being dogs or cats or insects, like the fellow earlier today. I ask them specifically, have they had perceptions of things that other people don't notice? I do tend to ask about delusions also. I'm not trying to plant ideas. I just want people to understand what it is I'm looking for, what I'm inquiring about. Delusions being, as I mentioned, somebody's trying to break in and do something bad, or there's somebody lurking in the bathroom at night, that kind of thing, or that my spouse is not my spouse, or some the things are going on there are things going on against me in my own home. So I ask those things.
Okay. I'm curious from the audience if you could put yes or no in the chat. Has your neurologist or your loved one's neurologist asked you those type of questions? Just curious.
Well, I'm going to interject at that point because this was published in the past by a group in London, good group. And they did a study where they asked people in the waiting room, are you having this? And then they asked later, did it come up during your visit, after the visit with the neurologist? Quite often, no. The neurologist didn't ask, and the patient or the care partner did not bring it up. And that's why it's often been unrecognized or under-recognized that people, although they're having them, they don't bring it up because people want to talk about the tremor. They want to talk about balance or other things. There's a lot to talk about with Parkinson's disease. And that's true. And I want to know about many of these other things as well. And time is limited. I have my list of things I need to go through, and the person coming to see me has their own list of things. But this is an important priority for me.
Okay. Thank you all for putting your personal experience in the chat. There was also a question in the chat that I think relates to you asking your patients this. Do the people hallucinating know that they are hallucinating?
Usually at the beginning, yes. They recognize it. Well, that's not real. That's not, that coat rack is not actually a person. The fellow I saw yesterday told me exactly that. My coat rack looks like a person. I see somebody standing by the refrigerator, and he knew very well that person was not there. He was seeing also a cat that he used to have, that he was fond of, that passed away, which I guess he sort of liked, but he knew that it was not correct. The issue is, though, unfortunately, and I don't want to be morose or cynical about these things, but as time goes by, the recognition may become less, that the insight, oh, that's a coat rack, that's not a person. That insight may dissipate or be lost as time goes by. And I can't predict at what time will pass if that were to occur. But that has been studied by a good group in Chicago years ago, relatively small group of people, about 50, but they followed these people over time and what happened to them. And the majority of these people over time tended to lose insight, stopped recognizing that what they were seeing was, or hearing or feeling was not in fact real, thought it was.
And someone asked, the nature of delusions are that people don't have insight. Is that correct? Or do people sometimes have insight about their delusions?
They don't. And I've had so many conversations over the years with people who are having a delusion, and I almost hate to bring up the common ones, but they have a delusion, and you cannot persuade somebody that what they say is not real. Oh, I know. I have evidence of my wife carrying on with the neighbor who's 90 years old. I've heard this many times over the years, and it is impossible to persuade somebody that this can't be so. How could that be? I'll cite another example. In my work in California, a nice couple, I knew them for years, and she had Parkinson's disease, rather advanced and severe. And she had the idea that her husband was hiding a girlfriend in the house. Her husband's life turned around her care. He got her up out of bed in the morning, he dressed her, put her on the toilet and took her off, took her to the breakfast table and breakfast. And all he did was care. He was devoted to her. All he did was her care. He rarely went out unless it was, sadly, to a doctor appointment with his wife. And she had this idea, this delusion that he was carrying on a relationship with a girlfriend that he hid downstairs in the house. They were both quite elderly, it made no sense at all, but she clung firmly to that concept. And was, again, how awful must that have been? I mean, her husband was sort of said, "Oh, how could I have a girlfriend? My whole day is, devoted to my wife."
I the I do just empathize. I agree with what you said on both sides, both for the person having those hallucinations or delusions and the spouse or family member on both sides. I mean, yes, how to feel tortured and then to feel accused. So,
Right.
just always so impressed by your empathy to point out both sides of these. So the last in our who, what, where, when, uh, why and where in the brain? What is the, physiologically, what is happening, or what can you tell us about that?
Well, that has been studied in a couple of interesting ways. One, it has been studied using imaging techniques in living patients, looking at what brain changes may be contributing to the appearance of especially visual hallucinations, which are the most common Parkinson's psychosis symptom. And what has been determined is that in a part of the brain called the temporal lobe, which is right around here, there is an increased density or number of receptors for a certain type of receptor for a brain chemical called serotonin. And these are the same receptors where things like LSD may connect and contribute to temporary psychosis, hallucinations, for example. So it was already known that LSD or other hallucinogens would be connecting, binding to these serotonin receptors. And lo and behold, those same receptors are increased. They are upregulated in the brains of people with Parkinson's disease who have psychosis or hallucinations. Also, brains were studied in patients who had passed away with Parkinson's disease. Some had psychosis symptoms, hallucinations, some did not. And they were compared. And again, they found the same result, that there was an upregulation or increased density of a very specific type of serotonin receptor in the temporal lobes.
Always interesting to know what's behind the symptoms. And I'm looking at the chat, and I think the the next set of questions have to do with, so many people chimed in that, yep, I got those. I hear something, I see something. Now what? So when your patients say yes to those questions, what's the next step?
Well, the next step is I want to know what medications they're taking, not just for Parkinson's disease, but for everything. Of all the many things that can go on in Parkinson's disease: overactive bladder, urgency, frequency of urination, and a medication that's been popular for years to treat that is something called oxybutynin or ditropan, which is an anticholinergic medication, similar to the one I mentioned at the outset, Artane, which caused or contributed to hallucinations in that patient I was seeing in Ann Arbor years ago. So there may be other medications that are being used, not for Parkinson's disease, that could be a contributing factor. So I want to be aware of all those things. I don't want my patients to use oxybutynin. It's great for the bladder, but it's not brain friendly. So I look for things like that. I also want to be aware of, are there other things going on? Especially if there's been an abrupt change. If somebody suddenly has really florid hallucinations out of the blue, they don't usually start that way. They start out kind of mild and occasional. I want to know, is there some other acute medical problem? Looked at the medication, so it's not the medication. Is there some other acute medical problem? Very commonly, people who have a urinary tract infection can have other things provoked by a simple infection. In the past, I found just about anything you can imagine that was a contributing factor. People had fallen and they had some bleeding on top of their brain, and that was probably a contributing factor, and it was pretty subtle. If you didn't know about the fall, might not have looked for that. When I was in California, one of my patients, so his wife called up, and he was having an increase abruptly, and I think I was gone, and my fellow, Dr. Markova, had evaluated him and found that he was in acute renal failure, kidney failure. And that was because he had a prostate cancer that he wasn't even aware of. And that's how it was detected, by the worsening of his aggressive worsening of his hallucinations. So I want to make sure there's not other medical stuff going on that I need to be aware of. And you have to be sensitive to things because it could be just about anything. Then if you, well, it's not that. And if, I think I'm pretty conservative, frugal with medication prescriptions for my patients. I always say, my role is judicious use of medications in treating Parkinson's disease. And I don't think I've got a lot of wiggle room to cut back on Parkinson's medications. I'm trying to keep it at a minimum to begin with. But if there is something that could be removed, then you want to try to pull back on medications for Parkinson's disease if you can. Often you can't. And then the question is what to do next.
And someone put in the chat that they have told their neurologist that they do have hallucinations, and their neurologist asked, do they bother you? And made the decision not to treat them. So once you've ruled out that it's not a separate issue, now what?
Well, if, for example, if I saw somebody recently who was seeing cats, and that was not particularly bothersome to them. And I had a patient years ago would see a little dog in his kitchen, and he kind of liked the little dog. Now, nobody wants to take more medication. I don't. My patients don't want to take any more medication than they have to. So if something is there occasionally, and I ask, is it threatening? Is it frightening? Is it disturbing in some way? And how often is it happening? I want to have some baseline information about that. And if it's occasional, they're seeing a dog in the kitchen, I don't think I would treat that, but I would make note of it. And I tell my patients and their care partners, if that's changing, if the dog is becoming a person, or threatening in some way, I need to know that sooner than later. Don't wait until the next appointment. Call me up and let me know. I need to know. So if it's occasional and not threatening, I look at other things that could be provoking. If they're not found, I would not necessarily treat it, but I would make it real clear that they need to be in close contact with me if there's some change.
And someone asked, I hallucinate, I see people that I know aren't there. I'm not worried about it. I am worried about delusions. If I have what I think are mild hallucinations now, is that a sign that it could progress into something more serious?
Yes. Sorry to say so, but the answer, quite frankly, is yes. It could. And based on that study from Rush, Chris Getz and his colleagues in Rush, some years ago, that is the tendency. No, not everybody follows necessarily that pattern, but yes, it could. And when I hear that from somebody, it makes me aware, and I don't want to sound all the alarms, but I would, at that time, if somebody's seeing people in their home daily, I would be thinking about treating that. And if there's no other provocative factors, I would be thinking about at least having a discussion about the opportunity or the choice of treatment, or a wait to see how things develop.
And this is a kind of a similar question. I hallucinated one time. I haven't since then. Could it have been a one-time thing, or do you think that this will progress?
It could be a one-time thing. That would be, I have to say, in my personal experience, I think that would be uncommon. It's there once, there's a likelihood that it'll happen again. Not necessarily get to the point that it's hair-raising or horrible or something like that. But they typically do not remit or go into remission on their own, unless there's something else that was provoking it, bringing it out. And a common provocative factor is going into the hospital. Don't go into the hospital if you can avoid it. That is an opportunity. You go into the hospital strange place, strange people, strange stuff going on is disorienting. And I cannot tell you how many times I've had patients who are doing pretty well at home, and then they end up in the emergency department or the hospital for some reason. I wish they wouldn't. And then things really break loose.
Someone asked exactly that, a hospital visit seems to really bring on the hallucinations, and then once they're home for 4 or 5 days, they taper off. Why is that?
I just think it's this, like if you have a bladder infection and it provokes the hallucinations or delusions, and then once you get over the infection, things can kind of settle down again. I think it's just the stress and disorientation of being in the hospital. And the hospital, wherever I worked, I'm not just picking on this place where I am now or UCI where I was in the past, any hospital where I've ever worked is a great opportunity for things to happen that in retrospect, that probably wasn't a good idea. And again, quite frankly, here we have a policy, which is mostly followed, that if somebody comes into the hospital with Parkinson's, they call me. Even if they're not my patient, they call me so that we can talk about what to do if these things are starting to emerge. There have been, I could cite many examples, people come to the emergency department or the hospital, hallucinations emerge, and then they get dumped a whole bunch of medications, and it doesn't help. It just sort of throws gas on the fire. So it's not a good place to be dealing with these symptoms.
Absolutely. Okay, the next overwhelming set of questions have to do with what is the medication? Are there multiple? What would you prescribe if it's at the point where you want to treat it?
Yeah, so there are realistically maybe three choices. And none of them are like perfect choices. So what has been historically used and still is, I think, with many of my colleagues, is a medication called quetiapine. It is an antipsychotic medication that's been around forever, almost as long as I can remember. It's also called Seroquel, and has been sort of the go-to medication for treating psychosis in Parkinson's disease. Now, the troubling thing from my point of view is that if I'm going to treat something, I want it to be pretty confident that it's going to work. And the issue with quetiapine, although many people say, "Oh, in my hands, it's very reliable," I did not find that to be the case in the course of my career. I used it, and I did not find it always satisfactory for my patients, from my sense of, oh, yes, we're making progress. And in fact, it was reviewed by the International Society for Parkinson's and Movement Disorders, to which I belong. And they published this a couple of years ago, looking, well, what seems to have good evidence that it works, and quetiapine does not, unfortunately. Another medication that's even older than quetiapine is called clozapine, and it does have good data, two good studies, one European, one North American, that showed that it does work. And I've used that many times over the years. But clozapine, also an antipsychotic medication, requires a weekly blood test. And you can only pick up the prescription a week at a time. The reason for that is that it has a rare side effect of inhibiting white blood cell production. And if you're not making enough white blood cells, that could be fatal if you've got a mild infection. So you have to monitor the blood cell counts on a weekly basis for 6 months, and then every 2 weeks for 6 months, and then every month forever after that. So that's a lot of burden to place on people who are already shouldering a heavy burden. So most of my colleagues don't use that. And since I moved here, I've not been using it much. The more recent choice is a medication called pimavanserin. The trade name is Newplaza, which was developed specifically for this niche. They thought, well, here's a problem that's pretty common in Parkinson's disease. The current choices are not optimal. And so this molecule was synthesized specifically to go to those receptors, those serotonin receptors I mentioned earlier, and intervene in the process of creation of psychosis, hallucinations, and delusions. So it was synthesized for that purpose. It was gone through clinical trials, which I did years ago in Irvine, and proved to the FDA that it worked better than placebo. So that is the medication that has FDA approval. The other two don't. that medication has FDA approval for the treatment of psychosis symptoms in Parkinson's disease.
Very good. And so those would be the pharmacological treatments.
Mhm.
Do you have any tips, or what do you tell families about, behaviorally or day to day? How can family members, um, better cope or deal or handle if their loved one with Parkinson's is experiencing hallucinations or delusions?
Well, the pandemic has just been the worst thing for all of us, but especially for people with Parkinson's disease who may be prone to having hallucinations or delusions. In the clinical trial, we had people go through a 2-week period. It wasn't really psychotherapy, it was just conversation. It was just connecting with people to see if that might help reduce the severity or frequency of the symptoms of psychosis. And for some, it did. So that's not a bad way to start. I mean, the worst thing I think is to be sitting at home in isolation in a chair and staring at the horrible news on TV all day long. That probably will serve to not help, maybe even propagate these kinds of symptoms. So just getting connected and reoriented and engaged in things of interest to the person with Parkinson's disease or to their care partner, I think is a good step in the right direction. There's one other thing I just want to mention when I was talking about those medication choices. Those are all classified as so-called antipsychotic medications because hallucinations or delusions are symptoms of psychosis. Not to say that this is evolving into schizophrenia or something else. All antipsychotic medications, all of them, quetiapine, clozapine, and pimavanserin, have a prominent warning early in the package insert about something that's frightening, but I bring it up with everybody, all my patients where I'm using an antipsychotic medication, a stark warning about increased risk of death in elderly people with dementia. Now, for some of my patients who I'm treating, they're not exactly elderly. They're younger than I am, and they don't necessarily have dementia. But I want everybody who takes an antipsychotic medication, regardless of the reason, to be aware of that and not go home and read about it on the internet. Have the conversation with me in the office and not go home and say, well, what the heck is that? He didn't say a word about that. And that's a frightening thing to read about and not have an opportunity to discuss it.
Absolutely. Dr. Google gets dangerous. Okay, there's a couple. We have a lot of questions. They're all good ones. Someone asks, they're considering DBS and wondering if that has any impact on hallucinations and delusions.
But and not in a good way necessarily. There have been isolated reports. I'm thinking of one from Hershey, Penn State Medical School, a colleague of mine, where I'm pretty sure they reported emergence of hallucinations after DBS. You would think, well, if you go through DBS, you can cut back on medication, and by cutting back on medication, maybe that would reduce the risk of hallucinations. I would be reluctant if somebody was having psychosis symptoms, especially frequent and troubling. I would be reluctant to go through DBS.
Very good. There's been a couple questions going both ways. If hallucinations and delusions are a sign of later Lewy body dementia, or if Lewy body dementia has increased risk for hallucinations and delusions.
Well, to the second question, yeah. So I would like people to be aware that this discrimination between Lewy body dementia and Parkinson's disease is really for, I think, research purposes. Lots of people would probably disagree with that. But if somebody starts out with cognitive decline and has hallucinations in the first year, and then on day 366, they develop a tremor or slowness, that's called Lewy body dementia. If they start out with a tremor or slowness and difficulty with mobility, and then day 366, they have cognitive decline, that's called Parkinson's disease with dementia or psychosis. So it's a very artificial separation, and I think there are lots of people, including me, that's probably part of a spectrum and not discrete diagnoses. Uh, but for just practice purposes, somebody who starts out with early in the first year or so with cognitive impairment and mild motor findings, then you think that it might be a greater risk for having psychosis symptoms.
Okay. Uh, do off times, if I'm off more, does that trigger hallucinations and delusions more?
Not that we know of, not that I've ever seen published. No, not that motor fluctuations, the wearing off or off time, really common. And I don't know of any correlation necessarily, other than that usually occurs after some time has passed, and maybe there's some correlation with duration of the diagnosis and having these symptoms, but no real direct connection that I'm aware of.
Okay. Um, let's see. I'll go next to, can you speak about delusions versus dreams? I
It's
have a hard, yeah. Is that enough of a question?
That's, I'm glad you brought it up because it's an important distinction. Because when I start having these conversations, people will say, "Yeah, I have hallucinations." But when I then a little bit more conversation, I realize they're talking about acting out dreams. They're asleep. So hallucinations and delusions are in waking state, not when people are asleep. Another not clearly connected issue is something called REM sleep behavior disorder, where people are asleep and dreaming, and they're dreaming they're playing ping pong and they're doing this kind of stuff, or they're fighting off a bear or something. So that's pretty common also in Parkinson's disease, maybe an early symptom of Parkinson's or even before the motor manifestations. Some people have argued that people who have that are more likely to have psychosis symptoms later, but that's not been established with certainty.
Okay. I didn't think that was enough of a question, but I'm glad that it was.
Yeah.
So a few people have asked, and Phyllis and Joel are asking, can you speak from the perspective of the caregiver? And let's see, there's been some related questions. If what do you tell the spouse or care partner or caregiver if you do start treating or diagnose the person with Parkinson's with hallucinations and delusions?
Well, when people have lost insight about the hallucinations, and again, delusions don't have insight. But when they've lost insight, it's very hard to tell people, no, there are no children with muddy shoes sitting on the white sofa. They're not there. Well, okay, but I know what I see. How can you persuade somebody that what they see, what they know is real, is not real? That's a very hard conversation and usually not productive. So in coping with these things, I would go back to what I mentioned earlier, talk about interesting topics, change the subject. Perhaps you could say, well, no, there are not kids on the sofa with muddy feet or any kids at all, but let's talk about whatever you like to talk about and bring some other idea into discussion and not focus and not try to win that argument because it's often unwinnable. I've done it in my office where I've tried to explain to people, does this make any sense that your deceased parent is in bed with you at night? No, but I know who was there. So that's probably not going to be productive.
And someone added that seeing their spouse and seeing a therapist has helped them cope with their loved one having these symptoms and accusing them of things. So
that's such a miserable situation where somebody is being. This is one of the more popular delusions, that my spouse is carrying on or having a relationship improperly with somebody else, and how painful that must be. I think having somebody to talk to about these things is, even with Parkinson's in general, is not a bad idea. Coping with a problem that we can't yet fix. We can treat it, we can make things better as best we can, but we can't stop it. We can't turn it around. And that is a hard thing to get up with every day, I think, judging from what people tell me. And I think just talking to somebody, a counselor or a therapist, about coping with chronic issues is not a bad idea.
And I want to invite, and maybe Kelly, you can put in the chat. Every Thursday, we have a care partner support group that meets online, and the attendees tell us, oh, David is giving me the thumbs up that talking these things through, even with peers who know what you're going through, can be really helpful too. So we invite you to join us on Thursdays. Open doors, open arms. The next question has to do with levodopa and dopamine agonists. They've read that levodopa and dopamine agonists can exacerbate or trigger Parkinson's disease psychosis. Is that true?
Well, sort of. People have looked for correlations, and I almost got into a fist fight with one of my colleagues who claimed that dopamine agonists like Mirapex or Requip or Nupro are more likely to cause hallucinations than, say, levodopa. I'm not sure that's true. We looked in California at a couple hundred of our patients who were hallucinating and those who were not, and there was no clear correlation to medication type, medication dose, and the same has been found with other people as well, other investigators. There's not a clear correlation. That group in Chicago gave people intravenous levodopa and they couldn't bring them out by giving levodopa by vein. They didn't provoke the hallucination. So it's not clearly a drug type related symptom or a dosage related. So I have my own biases about what things may be more likely. I mentioned those anticholinergic drugs. I think they're more likely and I don't use them anymore. A medication called amantadine, well, maybe. That's my personal bias. I'm not sure there's data to support that bias. But they all have, if you read the package insert for all those drugs, they all mention hallucinations as a potential adverse effect.
And someone asked specifically about Reitari, which is a form of carbidopa levodopa, so that would be addressed in.
Yeah, so it's Reitari is the newer form of carbidopa levodopa in a capsule with immediate release and sustained release combined together. And yeah, I mean, it could be a contributing factor, but I just want to emphasize that sometimes people have had hallucinations without medication or without very much medication.
Okay, and here's a good question from Shelley. Have you ever encountered a sort of false positivity among PD patients, a belief that they can do something that is in fact physically or cognitively beyond their capabilities?
Many times. Yeah, I hate to get into too many details, but working on the roof, climbing a ladder, sometimes driving a car, when clearly, when I'll say experiences in the past, I'd ask my patient, how's your driving? And they would say, fine. And I would see out of the corner of my eye the spouse doing this. So yeah, people say, I don't want people to perceive of themselves as Parkinson's disease or Parkinson's patients, but sometimes a conversation about what's realistic and safe is necessary.
But is that, the follow-up question, is that denial or a delusion?
I wouldn't say it's a delusion. There's an interesting phenomenon that people, I think, sometimes don't have. I mean, none of us have the same perception of ourselves as others do. I think every time I hear my voice or see my image, see a video of myself, I think, who's that? So I think that also applies to Parkinson's disease. And I don't want to be beating people over the head with limitations that this diagnosis can bring, but I do need to be realistic for them so they can be safe. I don't think it's a delusion. It's just an altered perception, probably, that we all have to some extent.
Yes. So this is an interesting question that might be beyond your scope, but this person says they do see a small gray dog from time to time. They know it's a hallucination. They've never owned a dog. They don't like dogs. What does it say about the human brain that I am hallucinating a small gray dog?
Yeah, that must be coming from the dog part of the brain. I don't know, but I've heard that many times. The other hallucination I've commonly heard with children, and if it's a child, more often than not, it's a girl child, not a boy. And I don't know why there are these recurrent themes, both hallucinations and delusions, that there are common things that people see. I'm not sure. And I hope I'm not frozen because you are. Am I frozen? No, okay. So I don't know why it would be a dog or why it would be a child, and especially a girl child. But Andrea, I think you're frozen.
Yeah, I think Andrea, we've lost her momentarily. It looks like her computer died, so she will be joining us again.
Somebody
as soon
asked,
as
one of the questions that I saw pop up was, I think somebody said, "How is Newplaza dosed?" It's once a day. Which is, again, nobody wants to take more medication, but once a day is, some people say, oh, I can tolerate one more capsule a day. I usually give it during dinner. The time of day is not critical, but I usually have people take it around dinner time or the evening time. The other thing that I mention to people when they're using that when I prescribe that medication, it doesn't work quickly, so they have to stick with it for, I would say, at least 4 weeks. Some of the data suggests that it may start separating from placebo, showing some efficacy at a couple of weeks, but I tell people it's at least a 4-week commitment.
Yeah, that makes sense. Well, are there any last thoughts you want to share, Dr. Hermanowicz, with our group today as we kind of wrap up for today's session?
Somebody was saying, do SSRIs, these are serotonin selective reuptake inhibitors, things like Zoloft and Paxil and Prozac, do they contribute to hallucinations? Not really, not usually in a big way. I don't think so. Other medications that are used in Parkinson's disease, sometimes for cognitive difficulty, like rivastigmine, also known as Exelon, which is FDA approved for cognitive change in Parkinson's patients. That might have a modest impact on these symptoms. In the clinical trial, there was a subgroup of people who had a lot of cognitive difficulty were not allowed, they were not in the trial. But there was a subgroup of people who were on rivastigmine, Exelon, and they seemed to do a little bit better when they were on the active treatment with Newplaza. She's back.
My computer just completely shut down. I'm glad everyone didn't leave.
I melted it down by talking too fast.
I overloaded the circuits. Well, thank you for filling the gap. And now I'm a little bit flustered. But luckily, Dawn put a question in the chat. Did we already cover that one, Kelly?
Which one?
Opicapone has been identified as provoking hallucinations here in the UK. Is it in the US?
Well, all Parkinson's medications have that potential. Opicapone, with the trade name here is Ongentys, is a once-a-day medication to try to extend the duration of benefit of levodopa by inhibiting one of the enzymes that degrade levodopa. So anything that's potentiating or treating Parkinson's symptoms has that potential. All of them do.
Okay. And this, because we're coming up on the end of our time, so this is a good, I think we only have time for 1 or 2 more questions, so this is a good closer. Is there anything in the research pipeline? What's coming next when it related to hallucinations and delusions?
Not that specifically. There's a lot of activity in Parkinson's disease in research therapeutics, which is so gratifying, but I don't know of anything specifically that I've heard about hallucinations and delusions. But the Parkinson's arena, I mean, it was like empty. When I was a fellow, there was not much going on, and a little bit, but not too much in terms of therapeutics being developed. Now there are several trying to get after the disease itself, which I'm hopeful about those things.
And someone put, while we have Dr. Hermanowicz, can you comment on the 2 new pumps that they're excited to come to market, hopefully sometime soon? Do you know what they're referring to?
Yeah, I do. I know those 2 new pumps. They are, so again, Levodopa, 1970 was when it came on board, and with carbidopa, I think 75. And still is the cornerstone of treatment of some, not all, but some of the symptoms of Parkinson's disease. And the problem with levodopa is it's got such a short duration. There's also, I mentioned, the gut is kind of an issue of, the gut may slow down and be unreliable to get the medication to the brain. So people thought for a long time, how do we bypass the gut and how can we give it more consistently so there's not this up and down stuff during the day? And one way to do that now is to put a tube through the abdominal wall and connect the outside of the tube to a pump that and a gel pack of medication that's called Duopa. But people may not want to have a tube through their abdominal wall, but another way to deliver that is a needle underneath the skin. And the company that has Duopa is working on that now. Clinical trials are underway. So you would insert a needle under the skin, connected on the outside to the medication that is pumped in continually. And the reports, I started doing that in California, and when I moved here, I'm no longer involved with it, but what I'm hearing is it works pretty well. There's another medication, which is a dopamine agonist, which is kind of like Mirapex and Requip and Nupro, called apomorphine. It's not morphine. It's not an opioid. It's a dopamine agonist. And that too can be pumped in continually during the course of the day. That's under trial right now. And from what I'm hearing, sounds pretty good. So these are options for people who may be thinking, for example, well, perhaps I should have DBS, but I'm not too crazy, deep brain stimulation surgery. I'm not too crazy about an elective brain surgery. Those two don't seem to fit, elective brain surgery. DBS can be life-changing for the right person, but it does carry a risk that not everybody wants to subject themselves to. So these needles under the skin with the pumping in continually, I think, probably 2023. I don't think next year, but probably 2023, those things will be available.
Like you said, it's exciting time in Parkinson's research. A lot happening, a lot coming to market.
It's sadly the fastest growing neurological diagnosis worldwide, outstripping Alzheimer's disease. According to these guys, Ray Dorsey, who's a former Californian now at the University of Rochester, published that this is, I'm telling you, people tell me every day, now that I've heard about Parkinson's, it seems like everybody's got it. They've never heard of it before, or maybe Michael J. Fox, Muhammad Ali, and people in the Alan Alda and so forth. But now that they're living, or they're a care provider, or care partner for somebody, it seems so common. And that commonness, if that's a word, is getting attention for therapeutic development, which I find exciting.
Absolutely. Well, it's a good positive note to end on. Thank you. As Curtis put it, you've been a wealth of information. Thank you for sharing this lunch hour with us. I learned a lot. And your, like I said, just your combination of expertise and empathy. As Mindy said, they're very happy that Dr. H moved to Santa Fe. I think that community is absolutely lucky. You know her. And yes, thank you. The thank yous are pouring in. So read those in the chat, and I invite everyone to turn on their camera if you've had it off. And we always like to close with a little moment of gratitude for this community, for each other, and for our speaker, and with a goodbye wave. So thank you all for being here, and thank you, Dr. Hermanowicz, and bye
My,
now, everyone.
my pleasure.